right, we are here with Dr. Dan Morgan, an infectious disease physician and epidemiologist. He is a professor at the University of Maryland School of Medicine, where he directs the Center for Innovation in Diagnosis. Dan, welcome to the External Medicine Podcast.
Great, glad to be here.
Before we get started, do you have any financial disclosures?
No, funding's pretty much from government sources, CDC, NIH, the Department of Veterans Affairs. I think that's it.
Excellent. So we want to get a little bit of information on your background and intellectual interests. I know that you've done a lot of work on medical overuse, diagnostic stewardship, infection prevention. How did you get interested in those topics?
Oh, I think I've always struggled with people talk about the fox and the hedgehog as sort of like different mental models. Like the fox sort of does a little bit of everything, and the hedgehog is very focused in on one thing. And I think I've often been told you should be a hedgehog, like be an expert in one thing and like know more about it than anyone else. And I've never been good at that. So I think it's that I moved to Baltimore. And I was looking for a job, and there was a group doing good infection control research. And so it seemed like the best place, the best people to work with. And so I started doing infection control with them. And then I've just kind of explored different things that seemed interesting and found myself, kind of far away from infection control at different points.
So most people in the field of medicine have heard of antibiotic stewardship, but I'm not sure how many are familiar with the idea of diagnostic stewardship. Could you give us maybe a potted definition and explain what you mean by that term?
Yeah, certainly. I think it's a term that's become more popular in infectious disease in the past 5 or 6 years. And I still think people don't always mean the same thing when they talk about it. So the definition that we've promoted for diagnostic stewardship is we've described it two ways. One is the right test for the right patient, promoting the right action. So really focusing on testing, being oriented around what gets the best outcome for patients, not just, is the test run in some, accurate fashion. And the other part is focusing on the aspect of implementing tests. So it's the process of changing the way the tests are ordered, performed in the laboratory, or reported to improve patient outcomes. And usually it's oriented around microbiology tests like Diff testing and urine cultures, say.
So what would be some examples of diagnostic stewardship as applied to microbiome testing? Aren't we just supposed to test everybody that comes to the hospital for Diff?
Some might say that, but no, so Diff testing is interesting because it's changed a lot just during, I think my relatively limited time in medicine. When I was a resident, we were using toxin testing, which is looking for, antigen and sort of like a fair amount of the toxin being present. And people always talked about this test being 60% sensitive and sort of arguing about how bad it was because of that. And we even did this funny thing where we would test every day for 3 days, which probably didn't improve the situation much. We didn't really know what it was compared to, but it was being compared to C. diff culture. And then PCR testing came along that amplifies small amounts of DNA from C. diff. And that became very widespread, and it really increased the rates, and it meant that we were treating a lot of people who probably had very mild C. diff or were just colonized and not infected. And so we realized pretty quickly there were problems with C. diff testing with the PCR. So then people went back to evaluating the C. diff toxin test. And now I think probably the most standard approach is a PCR test, and if it's positive, followed by a toxin test. And I think that's probably the best thing for patients, but also that's really been encouraged by public reporting of C. diff as a metric for which your hospital will be gauged on and reimbursed upon. And the CDC allowing whatever is the last test to be the definitive test for your rate. And so a toxin test is positive less often than a PCR test.
But I guess the sort of broader question of that's a very interesting example that you've sort of paired together 2 different tests in order to increase the accuracy of diagnosing what we care about, which is diarrhea caused by severe C. diff rather than patients who are just colonized. But in terms of when to order tests to begin with, you've spoken and written, I think in some instances also with your colleague, Dr. Kornstein, on this topic of diagnostic reasoning. How should physicians be thinking about being more accurate at diagnosing diseases and thinking about pre and post-test probabilities?
Yeah, great question. I mean, I think that, so this topic of diagnostic stewardship is really kind of a quality improvement type area. It's like focusing on how the hospital functions to try to make care be delivered better. But if clinicians, like us, were perfect at interpreting tests, you wouldn't need diagnostic stewardship, right? Like we would perfectly interpret the meaning of a test, and we'd say, well, it changes the probability some, but we're going to, be accurate and make accurate decisions based upon that new information. But we know that people are not that good at it. It's just not kind of a human function to be great at probability, and then especially not in settings like medicine, where we really get very limited feedback about diagnosis. And so, with Debbie Kornstein and others, we've thought a lot about this kind of the evidence-based model, I guess, for diagnosis, which is really essentially probability, where you would think about when you evaluate patients, how likely they are to have a disease or diseases, and then you would apply a test, and that test changes the probabilities. This is sort of the pretest probability updating based upon the sensitivity and specificity to get a positive or negative predictive value, which all sounds pretty easy, and we all learn it for like an hour or two in medical school, but it's really quite hard to apply to day-to-day clinical medicine.
Can you talk to us a little bit about testing wisely and what the goal of that project is? And maybe also if there's any evidence that physicians can actually be taught statistics and improve in their statistical reasoning.
Great. Thanks for that question. So testing wisely came out of, sort of this set of work. I sort of talk a little bit about how I pivoted from infection control to thinking more about diagnosis. And I think all along I've been a clinician in addition to a researcher. And so when I saw patients, it was clear that there were some problems about how we made diagnoses. Occasionally you see really bad problems, like someone who's misdiagnosed with the disease and gets treated and has a really bad outcome. Like in residency, I saw somebody who didn't have a pulmonary embolism, but got a VQ scan and was treated and then had a massive brain bleed and died as a result of that. And so I think I guess that it made me more aware of like these problems, like what do we mean when we say diagnosis? How do we think about that? And how are we making diagnoses? And I think I was always trying to figure out a way to make that into research. Like, how can I make this kind of observation or interest into something that would pay the bills, which is really, if you're an academic medical center, how you make it as a researcher. You find grants to pay for things. And there was these interesting series of studies where they'd asked physicians kind of simple questions, like somebody walked around the Harvard hospitals in the 70s, and then someone repeated this like 30 or 40 years later, where they said, you have a disease that's 1 in 1,000, it has a prevalence of 1 in 1,000, and you do a test with has a 5% false positive rate, you get a positive result. How likely they have a disease? And they got the same results in 1970s as 2014, which was the majority of people said it's a 95% likely they have a disease. And the reality is there's about a 2% chance based upon those numbers. And that just seemed to illustrate a problem that I thought, was more present in medicine than just being like a math problem and showing that doctors weren't good at math or statistics, but it's just kind of like a reasoning problem more than that. Like when we see patients, how do we think through things? So we tried to repeat these with very bread and butter type scenarios, like simple questions like a 40-year-old woman with chest pain and no risk factors. How likely is she to have cardiac ischemia? And you get a positive stress test, a stress ECG. How likely is she to have ischemia with that? Or with a negative one, how likely is she to have it? And the true answer is like it's all very low. It's all like less than 3% chance for pretest probability, and then after a positive result, it's still probably under a 10% chance of ischemia, just because has a very low likelihood to start out with. But what we found is doctors way overestimated the chance of disease. And after doing that, we said, well, if we were going to try to fix this, how would we fix this? And we talked to a lot of people, read some different literature, like, sort of psychological literature around how to think about probability and decision making, and came up with the idea, like, well, we should make a video game, or we should make these online calculators that could help people understand these things. And we dove into it, not really thinking about how much time it takes or how hard it is to build things and keep them running. And yeah, we ended up eventually, thankfully, like finding the right people to work with and getting things done, and having a video game that can at least teach people what a psychologist, Gerd Gigerenzer, has described as natural frequencies, kind of a decision tree type approach to understanding diagnosis that seems to work better than kind of 2x2 table type method that we typically teach in medical school.
That previous study that you did with Dr. Kornstein, the accuracy of practitioners' estimates of probability of diagnosis before and after testing, is a topic that we explored with her in our previous interview. And one thing that strikes me from this particular study is in the description that you use to prompt people with, here's the pretest probability, or here's the scenario, and you can determine your own pretest probability. And then you give, scenario of like pneumonia or cardiac ischemia, breast cancer screening, UTI. The test results are presented in a dichotomous, it's either a positive test result or a negative test result. So take the example of like the positive stress echocardiogram. Like, there are so many different ways a test could be positive. And so like, I guess I'm curious how much practitioners, when they hear like, oh, okay, the test was positive for breast cancer screening, if they are just assuming that this is like a grade, stage 5, like very obvious disease, rather than, this is, suggestive of maybe something.
Yeah, I mean, I think this is a real question when we talk about a lot of diagnostic tests. I mean, there's a few you get that are kind of just positive or negative, right? Like say a COVID antigen test. I mean, even that, like there probably is a spectrum of results. Like you could have like a faint line on your COVID antigen test, or you could have a very dark line. And but that one is generally kind of a yes/no dichotomous outcome. And we all know that probably for most tests, there's a range of positives, sort of like there's kind of clearly negative, and then like a range of abnormal that gets increasingly probably relevant. Like say a troponin test is a good example where you really have clearly quantified numbers. Having like a mildly abnormal troponin test probably doesn't mean that much, but having like a very high test, very very elevated test means more as far as indicating cardiac ischemia. So that is a problem, although, I mean, a lot of it gets at, well, what's the perfect way to describe test? And there are a few tests where they have different cutoffs and they're described in different ways, like a BNP test for heart failure was initially described this way, and I guess even like a VQ scan for pulmonary embolism essentially was described this way. You have like, normal, low probability, medium probability, high probability. With a more definite positive, I think obviously meaning more. The trick is, one, it's hard to find numbers to represent what that means, and I think people tend to respond to the mildly positive cases often in a similar way. Like say a chest X-ray that's has a small infiltrate in it, and read as can't exclude infection. That often means pneumonia, right? In the hospital, that person's getting antibiotics, and unless they have some other explanation. And I think that's, I mean, I'd say for UTIs, like something that's more in, my area that I work in all the time. It is basically a dichotomous outcome. I mean, we say greater than 100,000, greater than 10,000 organisms, but I think people often treat it as like it's positive versus, or negative. And that nuance isn't there as much. I would guess with mammograms, that's probably the same, that like, people aren't necessarily like looking at them who are recommending biopsies. They're, I think they're kind of like, well, if you're abnormal, you go down the pathway, even if like, yeah, that's probably ductal carcinoma in situ, or, it's mildly abnormal. It's not like a big mass that they identified. So, I mean, I do think that's just like one of the realities of testing, that there's a range of positives and that having a more dramatic positive means more. But the only way we can kind of quantify what does a test result mean in real life versus real clinical disease is like deciding some cutoffs and trying to, figure out like how predictive it is, like how much it changes the probability of disease. And it'd be great if we had more information about this. I think, there needs to be more clinical studies to really make sense out of that.
Do you see a role for AI in the electronic medical record as an assistant in a way when it comes to not necessarily steering physicians to, no, you shouldn't order this? What is it called? Clinical. I feel like a lot of those clinical support pop-ups are super annoying, but just telling the physician, like, based on what I'm seeing in the medical record, the pre-test probability of this person having what you want to order this test for is small. And if it's positive, it's more likely to be a false positive than a true positive. Because I do think that that's a problem overall within medicine, is that people tend to view these tests as magical. If it's positive, it's positive. It's negative, it's negative, and not think about false negatives and false positives. At least I rarely hear people actually talk about that.
I'd agree completely. I mean, I think I like that you described them as magical. During the pandemic, there was an article about antigen testing for COVID. This idea that like, if we just did antigen tests, we could end the pandemic in 2 weeks. Which was obviously false from a distance, but I think Slate described it as like the magic test hypothesis, and that's kind of what happens in medicine. I think still that we're often too busy, we're kind of rushing through things, and people order tests, and then once you have test results, you can just kind of put people into an algorithm based upon those results, when tests just aren't nearly accurate enough to do that. I mean, if tests were perfect, it'd be easy, right? And like an HIV test is probably a pretty good one. You could really put people into a certain algorithm based upon that. But most tests need to be used on the right patient to get the right outcome. So back to the question of AI. I'm skeptical of technology, like leading to big changes. I mean, I think clinical decision support, people have been saying that's going to, be a revolution in medicine for like 40 years. And, probably hasn't changed that much. I mean, I think it is helpful, especially if it's built well, and especially if it's giving clinicians what they want at the moment to make their lives easier versus annoying them as they're trying to go through their workflow. Like say the center criteria for strep throat, like people kind of like that because it helps them decide what to do, like antibiotics or not, and it's and they're kind of reaching for it when they need help versus like having it kind of imposed upon them. So I'm skeptical of technology, but I still think AI probably will change medicine. I mean, there's a lot of big money, a lot of the electronic health record people are investing in it, and the large language models seem quite good at predicting what physicians do. I'm going to mention a competitor of yours, but I don't know if you know Adam Rodman. He has Bedside Rounds, which is a good podcast on the history of medicine. But he's a hospitalist up at BI Deaconess in Boston, and he's gotten very into. I mean, he's been into I think historically the idea of like using machines to aid physicians, or like machines as doctors, which has been an idea for a long time. But it's never really panned out very well. With AI and with these large language models, it is interesting. Like, I think he'll have an article coming out, I don't know, I mean, I think actually in the next day or two, where he tried to train, he used ChatGPT he trained it on New England Journal of Medicine cases, and then fed it new cases that it hadn't seen before, and it did pretty well compared to physicians. Likewise, we've tried to use it on some of the cases that we described in that article from JAMA Internal Medicine in 2021, like the accuracy of clinician predictions, and it looks like it does better than the average clinician. I mean, I think that like average clinicians aren't taught how to do probability really, or don't think about it on a day-to-day basis. So it's not that hard to outperform. But I do think AI is probably going to become a bigger part of that. I think how it's implemented into a medical record is really the tricky part, right? Because I mean, I don't know, you probably work with Epic where you are. And it's really hard to even like build a BPA into Epic that is smart enough and looks right that it's not kind of annoying or distracting to clinicians. So I think the biggest question will be the interface of how it happens, because I think that probably the computing power is quite good for the questions that occur in medicine, but I just think maybe the current EHR systems aren't that flexible for it.
We'll have to see what OpenAI and Microsoft and Epic all come up with. Supposedly they're working on something now. In terms of the ability to improve the statistical reasoning of humans, do you have a sense that by working with the tools currently available, or more education, that you would actually be able to produce physicians who, as a result of understanding the pre and post test probabilities, would be less likely to order unnecessary diagnostic tests?
I mean, I think that's a big question. I would say there isn't definitive evidence one way or the other, but I think it's probably true that physicians will be can be better at that if they engage in training. I mean, humans, we like to say humans aren't good at statistics, they're not good at probability, but humans are very good at probability when they get feedback, right? I mean, like gamblers are pretty good at like saying like, oh, how likely is this to happen? Or, chess players are pretty good at figuring out like, when you make a mistake, what's going to happen to you? Or, when people watch sports games, they're pretty good at making predictions and accepting uncertainty, right? You can say like, my team's up by 15 points. And, now I see like, if you, look at them on ESPN or something, it will say like, 95% chance of winning. But we all, know that like, well, we'll see, like that may change. And, and it's sort of constantly modifying. So I do think if there's feedback, humans are pretty good at accepting uncertainty and understanding probability. But I think in medicine, even that concept is kind of hard. Like we're not used to saying, oh, I'm admitting somebody for this and I'm not really sure what they have, even though that was often my experience in residency, I think, right? Like a nursing home patient who comes in with a fever and problems breathing, and it really feels unclear what you're dealing with, right? And you get new information and it, makes it sometimes a bit more clear, but it usually doesn't feel like kind of an obvious, definite case. Even if, you find an infiltrate on their chest x-ray or something, there's still uncertainty around that. And you usually treat them for a few things at once and, they get better or they don't. And, you take different steps if they don't get better. So I think, but I think clinicians can get better. I mentioned earlier this guy, Gerd Gigerenzer. He's a psychologist from Germany who trained in the US for a long time. But he got into the idea of, it's essentially applying decision analysis to how we think about test interpretation. He called it natural frequencies, but it's essentially like forming like a decision tree and trying to teach people to start out with the pretest probability as kind of the defining factor of understanding what a test result means. And so like, if you were starting out, seeing a patient who had like a 1% pretest probability of disease, you'd say, okay, let me imagine 100 people. Well, 1 will have disease, 99 won't. And then you say, okay, well, we have, I have a sensitivity and specificity of a test. So the sensitivity applies to the one who has it. If that's high enough, you say, okay, that one person will probably be picked up. And then you say for the other people who have a positive test result, all of them are going to be negative. So 99 people who are on the other side, if a test is say 80% specific, well, that means about 20 will be false positives. So then you have like 20 false positives and 1 true positive, where you can say, well, that means about a 5% chance, that a positive means they have disease. So you can work through this decision tree much more easily than like a 2x2 table, where people, at least the way it's standardly taught in public health, we have a 2x2 table and you sort of enter the population at the bottom and you go backwards to calculate the columns and then kind of work through the rows to get the answers of a positive or negative predictive value. So there's this method of natural frequencies that he showed worked better. You can do it with visual displays, like have a visual grid that shows how many people have it and how many would be positive or negative. And then getting feedback is the other key part, that people get answers so that they can sort of learn if they were right or wrong, and they can, question their decision making if they got the wrong answer, especially if they were quite wrong. So I do think people can learn, but I think it's a challenge to get people to learn how to do it and apply it in their day-to-day practice.
The issue of feedback is an interesting one. It's, I'm sure one of the important factors that Kahneman talked about in his collaboration with Klein on developing expertise. And I think that you could probably attribute the majority of the incredible rise in USMLE Step 1 scores over the last 20 years to the proliferation of all of these resources to take the tests or practice tests and test yourself, and Anki cards and databases of questions, and learn what the test wants you to say, learn the correct associations. But I'm not really sure that those types of processes exist that much within medicine, or as much as we would like. And I think this sort of bleeds over into the next topic that we want to talk about with you, which is medical overuse. Because it's a pretty common thing for me at the hospital to meet conservative, so-called medically conservative physicians, not in the sensible medicine, Adam Seafu, Vinay Prasad, Andrew Foy type way, but the other side, where we're just going to order these extra tests just in case. And I know that we have a way to measure medical overuse when it comes to large data sets. And maybe you could talk through how we measure medical overuse in that context. But in terms of determining in an individual, did I medically overuse in this particular instance, I feel like that's a much harder problem to kind of tackle, to allow the feedback for changing one's use of medical resources in any particular circumstance.
Great. So medical overuse, I think it's a great topic. And I think even, sort of like trying to get it established as a topic, is something that I was very invested in. And I think really when I started working with Debbie Korenstein up in New York, it was this interest around this idea of medical overuse. We weren't even sure exactly what to call it. I think sometimes people called it overuse, sometimes people called it avoidable care or overdiagnosis, which is kind of a part of it, overtreatment. So there's sort of all these different terms that kind of circulate, and I think were a little bit confusing. So I think one of the things that I think was a success really of some of the work that I did with Debbie Korenstein was trying to get people to call it medical overuse at least. So there's like a big category that includes all of these different things. You correctly identified that, there's these different studies of overuse where they try to look at administrative metrics, basically. So, it's essentially the same thing as performance metrics. So they, there's certain things like a person who has an MRI of their back ordered with less than 6 weeks of having initial back pain without some kind of, concerning neurological signs or symptoms. They're largely taking the choosing wisely items that have been developed, where physician societies said, these are 5 things you shouldn't do, and trying to apply them to administrative data where we can, where that can be distinguished in the clinical data. The problem is, like, much of medicine is probably in this gray area. I think there's really obvious overuse, and that tends to be kind of like related to screening or something else where you can say, well, there's an age range we recommend this in, and if you're outside the age range, don't do it. Which I feel like makes medicine a little bit too black or white, that there's this grayness to medicine more, that there's a lot of things that, I think there's probably a lot more overuse even than we identify in those surveys, where they, may argue that, say up to a third of all medical care could be overuse. I think there's probably, that much or even a little bit more that is probably, kind of useless medicine, or, that's medical care. If it wasn't provided, wouldn't make a difference to the patient. They're not improved because of it, and they're sometimes harmed. But it is very hard to figure out on an individual level. I mean, there have been some studies where people do like chart reviews, but then it gets into the subjectivity, right? Of like, should you order this test, or should you order 10 tests instead of one test? And I mean, I think there aren't sort of strong criteria to say this is all overuse and this is not overuse. This is appropriate medical care. I mean, I also think that it hasn't been a focus really. I mean, I think that medicine has a huge push to not underuse care. That, like if someone didn't order a test on a patient and they ended up having a disease, that's, very clearly a lawsuit, and that's very clearly like a medical error. If you didn't, you didn't do a stress test, and, you didn't order a troponin and someone who ended up having cardiac ischemia, well, then, it's very much like that was a fault. That was an error of omission and so it's, kind of the standard format of how we regulate medicine. But we don't really think much about like doing too much. There's very little criticism of that, or even I think, way to standardize that. There's been a push, I guess in the 90s, there was a push for unnecessary surgery, because it was clear that some surgeries were being done on people who didn't need them at all. And so Congress got involved. There's been occasional pushes of like, unnecessary cardiac catheterizations and other things, but they're really the extreme cases where someone really has no indication. It's not kind of the anxious, nervous clinician who sort of orders all the tests on everybody who comes into the ER, even though that probably is worse care for them than somebody who was kind of thoughtful and used tests that were appropriate for that patient, but didn't just test them without a reason.
I'm going to try to articulate, I guess, the alternative perspective that could be raised in favor of, I guess I wouldn't call it medical overuse, but ordering more tests rather than fewer. Physicians make lots of decisions. Decision fatigue is a real thing, and particularly in acute care circumstances, take the emergency department. It's better, as is at the University of Maryland Midtown campus's emergency department, you have panels of tests. Okay, this is a chest pain rule out. Here are all of the boxes. I'm going to click most of the boxes and get things: chest x-ray, troponin, EKG, throw in a UA. Why the UA is in there, I have no idea, but it's on the checkbox, so we're going to throw it out. The goal of which is to really avoid, I think in some cases, legal liability associated with missing one of those things, as you mentioned. I think that some of it just seems to be like a cultural phenomenon. In some cases, it's like a hospital policy. You have in previous talks identified that there are certain areas in this country that use more medical resources than other areas without any improvement in outcome. Do you have any sense why that is the case?
Yes, so there's I mean, a lot of this comes from the Dartmouth Health Atlas. There's a group of health researchers at Dartmouth that was Jack Winberg was kind of the father of this group. And so they started looking at administrative data that's available across the country. So Medicaid, Medicare data related to spending. And they could break it down by region. And so essentially, they could look at how often people did certain medical things, ordered tests, provided treatment, did hip replacement surgery, used ICUs, sort of all these different services that are billed for, and thereby you can identify them. And they created these maps that, I mean, you can pull them up online, I think still, and have interactive maps where you can select for different items. And what they found is that there's big differences as far as how often things are used. Certain parts of the country, like large cities on the East Coast, much of the South, Southern California, large cities, there's just a lot more medical care provided per capita than areas of, say, I mean, especially the Pacific Northwest and and just kind of the Mountain West, where there's just less medical care used by people who are there. And so they tried to look into this, and they're trying to look at, do people have better outcomes related to it? And they essentially found that when they adjusted for different factors, people did no better, and maybe even there was a signal towards people doing a little bit worse with certain outcomes in places where they did more. Elliot Fisher, I think, was the first author on most of these papers, and some of this went into the ACA healthcare bill, like thinking about how to finance insurance. Well, it was an awareness of this sort of supply sensitive care, that if things are available, they will be used. There's a great variation in the amount of ICU beds that are available by hospital or even by city. And if there's many more ICU beds available per capita, they will be filled. And really, there's just sort of cultural differences seem to be the driver of it. That you guys have probably moved around a little bit, and I've moved a few times in my medical career, and it's just interesting to see that there are different practices in different places. And it's hard to say why. We obviously all have the same science kind of accessible to us, and even the same guidelines, but you realize that sort of what's considered acceptable or normal varies depending on where you are. So I think that, at its root, the variation in the amount of healthcare that's used, 2 or 3 times increase in the amount of testing in some places, at its base is probably cultural, and it's mostly related to medical culture, although some of it's related to patient culture too, what they're accustomed to getting when they go to see a doctor, if they're going to get tested or not, and how they're going to be followed up, and that kind of thing.
Let's talk a little bit more about an abundance of precaution with respect to contact precautions. In 2012, you were on a paper that was a randomized controlled trial about gowning and gloving in ICUs. Can you tell us a little bit about this study and what exactly was being tested?
Yeah, certainly. And this is funny. I think on your initial emails, you talked about contact precautions. So it stirred me to pull up some old papers that I hadn't thought about in a while, because I feel like this is a subject that I was really invested in for a while. And then I got just a little bit bored about it. Like, it was this big debate, and every year we had the same debate at our meetings. And I was like, what are we doing? And I moved on to diagnosis and sort of more general medicine, because it's like, I don't even care what people do. We've debated this back and forth to ad nauseum. But so this trial was pretty great. So in infection control, we hardly have any trials because number one, it's hard to do, because if you're looking at transmission of bacteria or something, you need a cluster trial. So, what happens to one person affects somebody else in that ICU. So you can't do individual level trials of ICU patients for contact precautions, because you're trying to look at the spread within the unit as a whole. And so cluster trials have kind of a great history of use at times, but they are difficult because you need a lot more people to do them. And so, I guess like any randomized trial, it's just a lot of work to do a randomized trial. And this is the only real kind of high level randomized trial I've done. And I think after that, I swore I wouldn't do another. But so in this trial, my boss, Anthony Harris, who's more pro contact precautions than me, got this big grant to do universal gowning and gloving in intensive care units. And so it's the idea that for all patient contact, people would wear gowns and gloves when they went into the room, and take these gowns and gloves off when they left the room. And this was to be compared to standard practice, which was to wear gowns and gloves for people who had multi-drug resistant organisms. So things like MRSA, VRE, or some of the resistant gram negatives, and that they knew that the patient had those things without doing active surveillance. So it's trying to do standard precaution, standard care, basically standard infection control, versus kind of an enhanced, more aggressive form of gowns and gloves. We recruited 20 sites. It was one ICU from each hospital per site. And we had a roll-in period where we collected the outcomes. So we swabbed people when they came into the ICU and swabbed them when they left the ICU. And the outcome was if they came in negative and if they left positive for MRSA or for VRE. So we had a roll-in period, and then we randomized sites. So we had like a month where we analyzed results, and then we told 10 sites that they were randomized to wear gowns and gloves all the time, 10 sites that they were going to just do same care that they'd been doing in the months prior. And then we studied people, I believe it was for about 12 months for an intervention. And it was a lot of work trying to figure out how to get people to use to use gowns and gloves the way we were telling them to, how to get people to not use them the ways that, we didn't want them to in the control arms. We visited each site, which turns out it's a lot of work to fly around the country and visit sites and walk around, and see what they're doing in their ICUs. And we had people monitoring the use of gowns and gloves in their ICUs to figure out, to make certain that they were adhering to the intervention that we had assigned them to. And so after we were finished with this study, we analyzed the results, which was acquisition of MRSA or VRE. And the primary outcome, which was acquisition of either of these, was no different between groups that used universal gowns and gloves versus standard contact precautions. On a sub-analysis, which is often sort of looked down upon by clinical trialists to do sub-analyses if your primary outcome is negative, there seemed to be an effect of reduced MRSA transmission in the people who used universal gown and gloves versus those who didn't, and no impact at all on VRE. And so even though we're talking about universal gowns and gloves here, this has been sort of the study that I think has people have used a lot to talk about contact precautions, which was already in place in both arms of the study. But essentially contact precautions are gowns and gloves. And so this was using a lot of gowns and gloves versus like kind of a moderate amount. And depending on who you talk to, we had a positive study or a negative study. Either it prevented MRSA or it didn't. I mean, I think the takeaway is probably that there's a very marginal effect, if any, and I think the very smallness of the outcome probably is the best information. That if it's positive or negative, it's kind of a minimal effect regardless.
There are a number of interesting things about this trial. One of which one of the secondary outcomes was healthcare visits. And this is the quote from the paper. Healthcare worker behaviors were affected by the intervention. The mean number of healthcare worker visits per hour in the intervention group was 4.28 versus 5.24 in the control group, for a mean difference of essentially minus 0.96 visits per hour, meaning there was one fewer visit per hour comparing the two groups. I'm curious if you think that significant difference, granted it was in a secondary endpoint, would have larger implications for things like anxiety, depression, delirium, not only just in terms of the number of visits per hour, but I don't think that the trial, to my knowledge, measured like amount of time spent in the room during the visits that did occur. Yeah,
I mean, thanks for reading the article, first of all. After you write something, it's always a question about, people paying attention to it. And this study has been, I guess, very rewarding that way, that it seems like people continue to read it and debate about it, which is sort of what you want, is what I want the most out of my work, at least. So you raise a good point, which has really been one of the consistent findings with contact precautions also, like in other studies where they look at patients on contact precautions versus those who are not. Healthcare workers go in the room less often if you're on contact precautions. And, to the two of you who are healthcare workers, is probably no question why, right? It's a bit of an annoyance to put on gowns and gloves. If you're thinking like, do I stop in and check in with them? Let me just wait, and especially say like if you're a nurse or a technician, that's really who goes in to visit patients, right? Doctors go by like once or twice a day. They're not around very often compared to the people who are in and out, on an hourly basis. And so that annoyance of having to put on gowns and gloves, it's not a lot of time. It takes, less than a minute to put them on, but it's enough to make you say, should I stop in? No, I'll come back later, or I'll try to bundle care. And And in other studies, we have looked at the total amount of time. And what that found is that there were fewer visits and a little bit, there was less time, but it wasn't quite as dramatic. So people do bundle their care a little bit. And nurses may, instead of going to give a medication and then come back like 5 minutes later to do something else, they may go in less often and try to sort of do everything at once, so they don't have to take off gowns and gloves in between. But that is a clear finding that healthcare workers visit people less often if they have to wear gowns and gloves to go in to see them. And that would be the mechanism for a lot of these other potential adverse events that people talk about with contact precautions. And that's sort of raising the idea that are people on contact precautions more likely to have, depression, anxiety, delirium, or even, more medical adverse events like falls or, adverse drug events, that kind of thing. And I would say that, truthfully, the adverse events, in this trial, we did look at adverse events. We had people do chart reviews at each site on 10 patients per month per site, which seemed like kind of a small number until you actually try to get each site to do it. And you realize that it's just a ton of people, and these chart reviews for adverse events can be pretty messy to do. It takes a fair amount of time to look through a chart and say, did somebody have a harm that resulted from medical care and not their underlying condition? But we did look at that in this study, which was the only study that's tried to randomize people to gown and gloves versus not. And we didn't find an increase in adverse events, whereas some earlier studies that were just observational had found that those people on contact precautions had more adverse events than those people who weren't, and suggested that it was the contact precautions themselves that caused it versus it being a marker for patients who are older and sicker and have more comorbidities, that kind of thing.
So what were some of the shortcomings of the trial, if you had to go through some of the limitations as far as being able to generalize the results to medicine broadly?
I think the biggest one is it's just sort of conceptually what we were able to study. There has been no trial of contact precautions, which is the big question people have, right? Should we use contact precautions for MRSA and VRE? There's been no randomized study to look at it, and there probably won't be, because the CDC is pretty discouraging of doing that. And the people who fund this kind of thing, or who say that ethically it's acceptable to do this, are kind of negative about the idea of trying to ask the question in the first place. So, I think that that's the biggest one. It would have been, if I really wanted to know, in reality, what works better for, medical centers taking care of patients, I would really want to say, let's use contact precautions versus not. And let's randomize places to do that. And so instead we have a study which is kind of gets that idea, but it's not exactly the answering it. The other sort of technical type problem is that when you look at the rates in the pre-period versus the intervention period, for MRSA, we had a higher rate in those, and just randomly by chance, those places that were in the intervention arm had a higher rate of MRSA than those groups than the control arm. And so essentially, the rate of MRSA was 10 and 6, I believe, in the two groups. The intervention group had a higher rate before there was any intervention. And then after the intervention, the rates were very similar. So what we saw was there was a decrease that was bigger in the intervention arm than in the control arm, but they kind of got to the same place. So I think some of this is just the vagaries of doing research. You can't control everything, and we couldn't get those rates back in time to randomize based upon those. But you could argue that the MRSA effect was regression to the mean, that essentially those ICUs that had higher rates went down to kind of what was the normal rate in the study. And so they ended up in the same place as the control arms at the end. We'll never really know, is the reality. You won't know if hey, it was the intervention that brought it down, and so that's the 40% relative reduction in MRSA that we observed, or that it was just that, we happened to choose randomly we chose the wrong ICUs to apply the intervention to. And so it, appeared to be an effect that maybe wasn't real. I guess the other thing that people may bring up with it is like we were looking at a surrogate outcome to some extent. We were looking at acquisition of antibiotic resistant bacteria, which probably no one wants to acquire MRSA or VRE, but it doesn't cause illness in most people who just acquire it. We did look at HAIs, but HAIs are very rare events. And so we found no difference in HAIs, but we didn't think we would either because, there's like 1 or 2 HAIs per ICU per month with the standard CDC definition. So, we didn't show, everyone would agree, we didn't show any impact on clinical infections. What we found was a difference in acquisition of antibiotic-resistant bacteria, which is really kind of a surrogate outcome, which is correlated with infections, but it's like a few steps removed.
You recently published a secondary analysis of this trial on C. diff. What were you looking for in this reanalysis that you published recently, and what did you find?
Thanks for noticing. Yeah, so the bug study, as this cluster trial was called, the benefits of universal gowning and gloving, which is kind of funny since we argue if there were benefits or not. The bug trial has been reanalyzed a few different times, and so we had swabs on all these patients. We swabbed them in their nose and in a perirectal swab, and so the perirectal swabs are very useful because a lot of bacteria tend to live in the GI tract. And so there was a secondary analysis that looked at gram-negative bacteria, things like ESBLs and resistant Acinetobacter, that found no effect of the intervention. And then after that, I did an analysis of C. diff. And we cultured C. diff from these swabs. And so we were looking at, being able to identify acquisition of toxigenic C. diff. And what we found was very clearly no impact. If anything, there's maybe a slight trend towards like more acquisition with universal gowning and gloving, which I think doesn't mean that there was more, but I think it just means that there was no impact. And it's relevant. I think, again, we're trying to find kind of surrogate measures of do contact precautions work. We use contact precautions for C. diff, but we don't have great evidence that they work. And so, by randomizing people to get them who, as there was a certain proportion that were unknown to have C. diff and that were isolated, we didn't see any decrease in transmission. So it certainly argues, like, I guess sort of, it argues you shouldn't use universal gowning gloves to try to prevent C. diff. It probably argues that active surveillance for C. diff, which is a practice in some places, and some people have promoted it, where you swab everybody to see if they have C. diff, regardless if they have diarrhea. And then you isolate those who have a positive test, that probably does not have any impact, because we were looking at the difference between those people who are isolated clinically and those people who had like sort of unknown colonization, and we found no difference. And then I think, people can even extend it to saying contact precautions, which is maybe contact precautions for C. diff doesn't matter that much, at least not beyond sort of the standard way we use, gowns and gloves for people with diarrhea as part of standard precautions. So, it was a very clearly negative study, but I think a useful one that it informed guidelines to kind of argue against being more aggressive with gowns and gloves to try to prevent C. diff.
So let's say you get your own hospital, it's the Dan Morgan Hospital, for experimental infection control. What do you do? How do you change things? What do you feel like there's insufficient evidence on? What are you going to test? What are your ideas?
All right. Well, I think, contact precautions is obviously what we've been talking about. And I feel like that's one that clinicians are very aware of, right? Because clinicians have to deal with it every day when they see patients. A lot of hospitals have stopped using contact precautions. It was one of these things that I feel like when I started in sort of like 2007, 2008, it seemed kind of hard to imagine people didn't use gowns and gloves at their hospital. But, there were rumors that like UCSF doesn't use gowns and gloves, or Dartmouth doesn't use gowns and gloves, but no one really knew unless you were there. And so it was clear that some places didn't start doing these practices, and they didn't really have problems with MRSA as a result. Or they had the same problems that all of us had, that there, were waves of MRSA, especially in kind of the mid 2000s, just related to the pandemic of community-acquired MRSA. So I think much less aggressive contact precautions. I tend to agree with my boss, Anthony Harris, who he's more pro contact precautions, but they probably have a role in certain high risk situations. They're probably worthwhile in certain ICUs, or certainly like in the case of an outbreak. It's probably worthwhile to try to use them for like epidemic disease in kind of a in a limited time frame. But I think for endemic disease like MRSA or VRE or other things, they probably have very little value, and I wouldn't use those. I think trying to do sort of like interventions that focus on high risk moments, like say like the line insertion protocols, I think makes sense. Like they've been used for CLABSI reduction. I think focusing on trying to have appropriate antibiotic use, it's not exactly infection control, but I think we all know that people who have their microbiome disrupted are more likely to acquire bacteria, and and probably at least half of the antibiotics we use in the hospital are unnecessary. So I think more aggressive clinician education about like the harms and benefits of antibiotics as part of a stewardship program. Chlorhexidine bathing is something we talk about a lot in our field. I think that's a reasonable thing to do in ICUs because it's a once a day intervention that's not that burdensome. And, most healthcare workers wouldn't even know it's happening because, it's just when you give somebody a bath, you use chlorhexidine instead of using soap and water. I guess that would be a start, and that's without getting into like the idea of metrics and other things that, inform a lot of infection control. But yeah, I think contact precautions less often, which I'm glad to see. Actually, there's been a nationwide trend towards using them less without it being kind of with the CDC kind of pushing people in the other direction, but people kind of voting with their policies and just not doing it and not finding problems as a result.
Let's move on to a few rapid fire questions.
All right.
White coats. Should everyone be required to wear them, or should they be banned from the hospital?
Yeah, I mean, this, if you want to do a study that gets in the New York Times, study white coats or ties. I think doctors' ties are even, a better yield, just swab some. So I would say neither. They shouldn't be banned, but they shouldn't really be encouraged either. I mean, they're not washed often, and they often have bacteria on them, but they're probably not a significant source of transmission in the hospital. So I think people who argue either direction are probably a little bit hyperbolic. They're not causing most healthcare infections. They also, probably don't really inform professionalism the way that some argue.
What is one medical truth that very few of your colleagues agree with you on?
It's a good question. I mean, I think probably the biggest one that I would say is that probably most medical interventions have marginal effects. There's a few things we do that have a big effect, like treatment of certain cancers or treatment of HIV or in a certain surgical procedures probably, but a lot of what we do, the treatment of mild hypertension, the cancer prevention screening, and other things probably have a very marginal population level effect, and really should be kind of a patient guided, based upon their personality more than like kind of a requirement to be considered good care.
If you had unlimited funds to run a single randomized controlled trial, what would you fund?
It's a great question. I don't know. I don't tend to think that way very often because I never have unlimited funds. But no, I mean, I think that if there was a way to have a very thorough intervention with clinicians trying to, have a group that is really exposed to thinking about overuse and to trying to minimize unnecessary care versus standard care would be quite interesting. Because I do think there's a lot of practice differences probably between clinicians that relates to how aggressively we use medical care. And I think probably we could do a lot less and get the, at least equal outcomes. And, and if we knew how to talk about it and explain to patients what we were doing, we'd probably have happier patients. So they didn't have to, do as many useless follow-up visits and other things. So, if I thought I could change clinician behavior, it would be around trying to do less aggressive care in a more thoughtful way versus the way we do things now.
All right, last question. What is the most underrated article in the medical literature that more physicians should be familiar with?
Well, here's one that I think is very useful. There was an article in 1997 in Annals of Internal Medicine that was talking about diagnostic sensitivity and specificity versus analytical. I think it was by Saw. I may be mispronouncing or misspelling the name. I think Saah was the first author. But it was a short article talking about the way that we have these test metrics. The way that they're often published is based upon analytical concerns. So basically, like if you're in a lab and you run a sample on two machines, like how well does one machine compare to the other? Which is a worthwhile question. You want to have machines that work well, but they were arguing that the real question that clinicians have is how well does a test detect a disease in a patient? And so that they were calling that diagnostic sensitivity and specificity, and comparing it to analytic sensitivity and specificity. And if you look at the literature trying to figure out how well tests work, you mostly get analytic sensitivity and specificity, which is like how well does it detect a compound, versus clinical studies that could tell you how well does it detect disease. And I think if really that article, I think, was very good at shifting the focus towards what we should care about, which is how well does this test work on the patient in front of me as a clinician, and I hope all that lab stuff works well. I hope they worked it out, but I really want to know, like, when I use it in patients, what can I expect? And I think that article defined some of the concerns around that. And so I guess that's one that I go back to often and think that it was making a good point that really hasn't been picked up upon that widely.
Excellent. Dan, well, thank you so much for joining us on the External Medicine podcast. If people are interested in learning more about you or your work, where should they find you on the internet?
Great. I think just Googling me probably pulls up my university webpage, which has links to other things. But we have a Testing Wisely website, which is where most of my diagnosis-related work shows up. And otherwise, probably just like Twitter or something. If you want to just get like my random thoughts, and annoyances that occur here and there.
This podcast is for educational and entertainment purposes only. We do not endorse any healthcare providers or treatments. Our views do not represent the views of any official organization or institution. If you'd like to support us, subscribe to this podcast wherever you get your podcasts. Leave us a review, preferably a phenomenal review. Visit us at externalmedicinepodcast.com and tell your friends.